I'm glad to be here today with the other day when Doug Baker was with us, he mentioned when you have a really tough problem, one of the management truisms is you smother it with talent. I can tell you today we are smothering this issue of testing with, I would argue, talent better than any place on the planet. The difference, I think, in Minnesota is the quality of the infrastructure of our healthcare systems and the ability of the research communities that surround them with the University of Minnesota and other institutions and the experts you're going to be hearing from today to put together a plan that actually gives us the best chance, I believe, to do that massive surveillance testing that we're seeing works in other countries. It's working where it's been deployed. I'm proud to stand with these folks. You're going to be hearing from Dr. Jakub Tolar, the Dean of the University of Minnesota Medical School and Vice President of Clinical Affairs.
Good afternoon, everyone. This is a good day. This is a glorious day. It's an Earth Day 2020. This is one for the ages because out of all that globe that has been suffering under this pandemic, there is one piece of it, and that is the state of Minnesota that I'm the most proud of. This is why, because we have a leadership in the governor, in the commissioner, Malcolm, Commissioner France, and others that understand the enormous power of science in making decisions on societal basis. So that ability to understand what is essential but invisible, as Little Princess in Saint-Exupéry, that is what's behind our effective ability to respond to this pandemic. So thank you, Governor, Commissioners. Thank you for the leadership in the state. Almost equally, I am grateful to President Gabel. President Gabel is a visionary leader of the University of Minnesota, and she represents the land-grant university, which is the first dictum of which is to serve Minnesotans, serve the community, and really deliver on what we need to do in the state of Minnesota for the patients, for their families, and for everybody there. So whom I represent here are the people that are behind that science that has changed medicine and epidemiology, for that matter, from magic 200 years ago to actually something you can do something about. So we are no longer to be seen in this state as victims of this pandemic, but rather vectors. You can deconstruct that. You can do something about this. And all these prognostications, all these Twitter storms, all these, social media events. I'm not big on social media, but my teenagers tell me. It is the one reason that I can think of why the prognostication is important is to change it. Do something about it. And that's why Minnesota is different than others. That's why Minnesota and its university is seen as a information and action hub, national and internationally, because we have been able, under the President Gabel's leadership, to actually deconstruct that problem and represent, the science behind it. So what is the science? The science started from the, I'm going to talk about the testing because that's why we are here today. It started from some of our investigators to looking at that virus at a very, very enlarged way. And so the virus looks like a chew toy of your dog. It has these little spikes, and with the technology called cryo-electron microscopy, they've been able, at the veterinary medicine and the medical school, able to understand the interaction between the cell, which is the epithelial cell in the lung, and the virus itself. From that, we have taken that would be like beginning of March or end of February. We've taken that, and my Center for Immunology at the university has taken that and developed a antibody testing, a serologic, testing, whereby we can detect the response to that chew toy of your dog, literally speaking, the spike protein of that. And from that, we have taken it to the lab. And from that, we have scaled it up to the point that the commissioner, the governor, everybody else can use it. Because we are here ultimately as a land-grant university to serve Minnesotans, everyone. As you said, vulnerable people that cannot, practice social distancing, everyone across the greater Minnesota. And that's why we do this. You mentioned supply chains. Very importantly, if you can deconstruct the testing, being that the polymerase chain reaction for the molecular, being then the serology, if you can really take the individual modules out of the equation, you are independent. So the beauty of the testing at the University of Minnesota is that most of it is not dependent on the regular supply chains. It is in fact something that, I have a PhD. I came here 30 years ago to get a PhD in molecular biology. You can actually develop your test and you are independent. So you own your future. So we own the not just the mission of the university, but we own that gravity of the epidemic for the Minnesotans. The second group that I represent here are the clinicians. I think you and the governor mentioned it at the beginning. This is personal. This is 2,000 people is a statistic. If this is your grandmother, this is not a statistic. This is something that's gonna change you and me and others. For the rest of your life. So this is important because these clinicians that I represent, and with my partner James Hereford on the mHealth Fairview, we have this COVID-19 hospital in Bethesda, not that distant from here. That is where these selfless, utterly exhausted people practice not heroism. It looks like heroism for where you stand, because it's so distant. From their standpoint, it's an act of decency. I am doing my job. That's what they do. And my work, my service is to them, with my teams, is to support them with the protective equipment, with the ventilators, with the swabs, with the antibody testing, with the serology testing. That is why the University of Minnesota teams, we have started 2 months ago to build new lines of the masks, new lines of the low-cost ventilators, new lines of the molecular testing and serology testing, this COVID-19 hospital, research that goes behind. This is a different disease, by the way, than influenza. This is really different than the other coronaviruses. These are these small clots that go to the lung, go to the brain, go everywhere, to the kidneys. This is different, and we need that science to really, be able to do that. So what you need to know is we trained for this. This is, I'm an intensive care unit doctor. I'm a bone marrow transplant physician. I deal with people that are very, very sick. And we trained for this. We built for this. We have 6 health science schools at the University of Minnesota, with College of Science and Engineering, College of Design, mHealth Fairview, and of course, my dear friends and colleagues at Mayo Clinic are in that partnership together. So what we really are here to do is to provide that service to the greater Minnesota, not just Metro. People should get excellent health care, not because they live close to a big hospital or they have a good paycheck. No, everybody. The access to reasonable medical care is, in my opinion, a fundamental human right. It is something, that should be allowed to everyone. That's why I'm proud of this state. And we should move that inevitable initial emotion, which is that one of fear and pity, that all of us are exposed to, in the realm of the pandemic, to a scientific, moral, almost symbolic responsibility for the sickness of our Minnesotans. So I'm here for that, and thank you very much. So you need to understand that the anxiety that comes with not knowing whether you are positive or not is as contagious as the virus itself. And it's one of the phenomenal gestures, in this, that we can alleviate that anxiety with science. So the testing itself, the science behind it, it's like Google Maps. You know where to go. But whether you're gonna go, you need a leader. You need a governor and his team. You need a president and her team. You need somebody in the leadership who said, this is the intent. This is where I'm going, and you go out and do this. So this is exactly why I'm saying to you, this is simple. We do tough stuff, but PCR and ELISA, which is what the tests are called, they are simple as they get. My entry-level students, do these things on a routine basis. But what is not simple is the logistics of it. How many hundreds of the stations across the metro are we going to have? How are we going to get this to the greater Minnesota? How are we going to get it to tribal nations? How are we going to get this everywhere when people need this? That is, where the logistics and the planning, needs to come, for and foremost. So I'm telling you, this is simple in a way. The rollout, based on, the discussions we had today, this should take literally to your questions, 2-3 weeks, not more than that. And maybe less. I'd rather under-promise than, over-promise, and over-deliver and under-promise, right? Speed is an essential ingredient in success. So the faster we're going to do this, the better we're going to do.
Thank you.
Question for either of the physicians here about the accuracy of these tests, both the PCR and the serology test. How accurate is it, and how do you know that?
This is
That's the question.
Can I? Bill?
Go for it, sir.
This is a very good question. Of course, because any test, is only as useful as it's accurate. And we look at what we call specificity and sensitivity. I'm not going to go through the details of this, but you can get a test that is what we call false positive, which means that, nothing happened and, the reading, is positive, or false negative, that is you had, in fact, some, product in there and the test didn't show it. So when we did our antibody testing, in the development, we had 87%, on each side first, but then when we refined it, we were 100% there. So the inaccuracy, if you will, which is a part of any kind of a testing that you're going to do, is mostly a function of how you collect the specimen and how you take care of the specimen. So typically we would get the virus from the back of your throat, the nasopharyngeal swab. We would get the serology from blood. So obviously the ability to collect the antibody is a little less open to variants than getting a swab in somebody's throat. So the PCR, which is the molecular test, the nasopharyngeal swab one, that is the one that is more sensitive to how you collect the sample than the one on the serology side. I also need to say that, as in any science that we do, it's a reference range, that is important. So we have positive and negative controls. That's how we know that the different components of the reaction actually are working as we want to. And this way, we can assess the accuracy of the testing. The last thing I'll do before Bill comes over here is that one has to be careful about when, in the process of the dynamics of the COVID-19 disease, the testing occurs, because there's about 12, maybe 14, maybe 15 days at the beginning of that before you can actually see the antibody response. So if you test somebody on day 5 when they have already symptoms, because that is the average 5.2 days, of onset of symptoms in somebody who has the COVID-19 exposure, then you may not have, an antibody testing. And the fact that you will see a positive test later on does not mean reinfection. There's a paper out of South Korea that actually is misleading, because these 91 patients that they have tested and felt that they are reinfected, they are most likely the ones that have developed the antibodies a little later. There's another study out of Stanford in California, Santa Clara, 3,300 people that were tested there, and that's where, the underestimation of the number of people that are actually positive for COVID-19 was estimated about 85-fold. So, but again, we do this for a living. This is why we went to medical school. This is why we got our PhDs. We are, as the governor correctly said, we are here to serve with that collective, distributed expertise across the state with Mayo Clinic, all the healthcare systems, and the higher education facilities.